Okay. So I'm going to be talking about approaches today which involve working through parents, primarily for children 0 to 3, and really about how we can reach more children and families with evidence-based interventions. I'd like to acknowledge my colleagues at the Child Development Research Group at the university and also external collaborators who've contributed to this work who are listed. So the goal of the programs is to improve home environments and ensure that children have interactive caregivers and opportunities to learn. And there are a number of critical needs in moving forward on this, but we've really focused on two. One is the need for evidence-based interventions for children, which are feasible for implementation at scale. And to address this, as Raquel said, I'm going to talk about our pilot in the Caribbean of delivering parenting through routine child health visits. The other area that we've started to focus on more recently is the need to increase the number of persons in countries and organizations who have the skills to train and to supervise the persons who will implement these programs, and also, very importantly, the skills to maintain program quality. And so I'm going to talk about some work that we've begun more recently on expanding access to evidence-based, our evidence-based Jamaica home visit intervention, which was mentioned earlier, through a web-based training package and support. So the first project was a pilot of parenting interventions in the Caribbean in 3 countries. And when we designed the approach, we wanted to come up with an approach which was, in a sense, minimalistic, in that we didn't want to have to employ any extra staff at the clinics, and we didn't want to increase the amount of time or the frequency with which the parents had to come to the clinic. So this is kind of a bare bones approach. So we produced some films which showed mothers, and these were filmed in Jamaica, so these are Jamaican mothers practicing behaviors we wanted to encourage. And there were 9 short films, and they cover topics such as talking with your baby, praise, looking at books, and so on. And these are shown at each child health visit from age 3 months through to 18 months. So this is when the mother or other caregiver is bringing her child anyway to the clinic for her routine visit and usually immunization. We trained the community health workers to not only show the videos, but then to demonstrate some of the activities that had been seen on the films and to help the mothers have an opportunity to practice while they were at the clinic. And then the clinic nurses distributed some message cards which reinforced what had been seen, and on some of the visits gave out a few play materials. Just to very briefly summarize what we found, we did demonstrate benefits to the children's cognition and to the parents' knowledge of child development. The effect sizes are comparable to what's seen sometimes with more scaled-up home visit programs, but were less than the Jamaica weekly home visit program, which is not surprising because this is a much smaller, less intensive intervention. We didn't find any adverse effects of adding the ECD activities on children's nutrition or immunization status, which is important. And so we felt that we demonstrated that it was possible to integrate this intervention, as I said, requiring no additional clinic staff or mother's time, into the routine health services. I was asked to particularly think about some of the challenges that we face, and that wasn't very hard because there were many. But I think the key ones comes back to the design of the intervention itself, in that there are only 5 contacts from 3 to 18 months. So this is not many opportunities to interact and engage the parent when considering we're coming from a history of weekly home visits. So that's one of the issues. And most of those contacts are before age 12 months. After age 12 months, there's only the 18-month visit. So we do feel that this is a component of a more comprehensive strategy and likely to need additional complementary programs for children aged 1 to 3. The other issue that you won't be surprised about is the difficulties with the infrastructure and resources. The resources were stretched. Many of the clinics were very crowded, they were noisy. Some of the staff had not so much time, but this was primarily the nurses. I think the community health workers did actually have the capacity to do this. And so going forward, we need to ensure that if we integrate into existing service, we don't have a negative impact on what they're already delivering. One of the advantages that the Caribbean has, and also much of Latin America, is excellent coverage and compliance with child health visits. But this is obviously something that is going to need to be considered if you're taking it to places with less comprehensive coverage. So we could reach almost all our children with this approach. So all of these issues will need attention as programs are scaled up, especially where children's health and nutrition is poorer and where the capacity of health services is more limited. We also, with the help of Florencia Lopez-Bu at IDB, were able to estimate the cost, the annual cost of the intervention, which we estimated to be $14 per child if we estimated for all of the children we reached attending the clinics. And so we think this is a promising component of ECD strategies with potential benefits for large numbers of children. So moving on to the next area of work that we're doing, which is expanding access through training. So as you've heard, the Jamaica Home Visit Program has a strong evidence base. It's feasible in low resource settings and has been replicated in other countries. So we wanted to develop, and this is in partnership, I should say, with Grand Challenges Canada. And we are developing an innovative web package with training and technical support which is targeted to organizations in low and middle income countries. So our goal is to increase the capacity of staff in these organizations to implement programs, and so to be able to train the visitor who's shown in the picture at the bottom of the slide to deliver the program to the mother and also to monitor the quality of the program. And so the goal then would be for the child to have a more responsive, interactive caregiver. We've produced a whole series of films. So this year, the work started this year, and our focus this year has been on developing the program materials. So we've produced films in Jamaica, Peru, and Bangladesh, and the Peru and Bangladesh films were done in collaboration with CUNAMAS and iCD-DRB. So there are 3 15-minute films which demonstrate the steps that you would take in a home visit, and 28 short films which depict specific activities and concepts that are needed for training. We're also working on revising and updating the curriculum, which is designed for use by the home visitor, developing training manuals for use by the trainer, including a guide for use with the films, and a guide to how to adapt our program by the program leads for the specific needs of their country or context. In the coming year, we're going to be working with organizations in 4 countries who we've turned early users. And this is for us to learn what are the challenges with implementation and to maybe modify some things that we can still modify and to do some evaluation of how the package works. So in these countries, we will be providing some more detailed on-the-ground technical support, including workshops, helping them with adapting the materials, and very importantly, working on tools for monitoring and evaluation and training in how to use these so as to maintain quality. So really a lot of emphasis on how they would supervise and monitor the program. And just to say, the next step following that, well, hopefully by the middle of next year, we expect to have the films and materials online. And we'll be developing the technical support over the course of the year. We're hoping that the first organizations will do evaluation of some further evaluation of how it works so that we can further modify and develop the technical support, which will also be available online. And one of the things I just want to point out is also that the package is going to have a Creative Commons license, which allows users to adapt it freely for their needs, as long as they attribute the original to the developers, and also as long as they share what they've developed under the same guidelines. Thank you.